Okay, so we are going to discuss the examination of the hematological system.
Hello.
The hematological system, we'll look at the symptoms of hematological disease. Then we'll look at the signs of hematological disease.
Okay.
So when we talk about the hematological system, we are talking about the white blood cells, the red blood cells, the platelets. So these three cells make up the hematological system. In addition, we are looking at the liver, the spleen, the lymph nodes, and the bone marrow. So when we talk about symptoms, if there's a problem with the hematological system, then the symptoms would be those that affect these various organs or cells that I described. So symptoms of hematological system involve symptoms of anemia, because if there's a shortage of red blood cells, then you have anemia. So those symptoms would be present. Then symptoms of recurrent infection, because the white blood cells protect us from infection. So if you have a problem with the white blood cells, then you would have recurrent infection. Then prolonged bleeding because of the platelets. If there's a problem with the platelets, there's a dysfunction of the platelets, or if there's a decrease in the number of the platelets, whatever reason, then you have prolonged bleeding. Then because the cells are produced in the bone marrow, if you have hematological problems, it can present as bone pain. And then looking at the liver and the spleen involvement, it can present as abdominal distension. So in order for you to remember what these symptoms are, just remember the organs and the cells which are involved in the hematological system, and then you'll be able to remember what the a deficiency or problem would lead to. Okay, so let's look at anemia. Oh, Akosia, put the light on. I'm going to kill you. So patients with, oh, please give me a minute. Stop it.
Akosia doesn't like light.
Okay, please. So patients with anemia, they would present with peculiar signs and symptoms. Now, it's very important for you to take note of the age and sex of the patients, because if you look at women of childbearing age, the commonest cause of anemia is a menstrual loss and then pregnancy. And so the age is very important, and then the sex as well. Now, if you look at older women and then males, older women, they are no longer menstruating, and then males don't menstruate. So for them, the commonest cause of anemia is loss from the GIT, and would look at subsequently what are the areas that the blood can be lost from. Okay, so age and sex, very, very important when you are taking a history of a patient with anemia. Now, some of the symptoms are categorized according to the pathophysiology. So, you know that the hemoglobin is in the red blood cell, and that is what carries oxygen around. So, when there's anemia, there's decreased hemoglobin, and this would manifest as decreased oxygen transport. So, that would be seen as fatigue, syncope, dyspnea, and then angina, that is chest pain. Then as a result of the blood volume, the patient will present with pallor. Blood is red, so when there's reduced volume of the blood going to the various organs, you see that there'll be pallor of the hands, of the conjunctiva, of the soles of the feet, and all the mucous membranes. Then there will also be a increased cardiac output, because the body realizes that there's a decreased amount of hemoglobin and decreased amount of oxygen available for transportation. And so there would be an attempt by the body to increase cardiac output so that it will meet the oxygen demands of the various tissues. And so that will be seen as, or that will be felt as pounding in the ears and palpitations. So all these symptoms are symptoms of anemia. If a patient comes to you and says that I hear pounding in my ear, it is a symptom of anemia. And so you need to take cognizance and deal with it appropriately. Okay, now more symptoms of anemia. The anemia, when it's prolonged, can lead to congestive cardiac failure, and that would lead to symptoms like orthopnea, where the patient will say that he cannot lie flat, he needs to lie on some pillows so that he would feel comfortable, and that's orthopnea. Then there's also paroxysmal nocturnal dyspnea, where the patient wakes up at night panting for breath. Then they have tachycardia, increased heart rate, raised central venous pressure, which usually is seen as an increased JVP on the neck. So you see that the neck veins are distended. Then the apex beat might be displaced. So when you check the apex beat, it will be in the position further from where it's supposed to be. You can hear a gallop rhythm when you auscultate. You can also hear basal crackles when you listen with a stethoscope. And then when you examine the ankles, there will be bilateral ankle edema. So all these are symptoms of heart failure. So having explored the symptoms, sometimes you may be lucky to have some symptoms that will point to the underlying pathology. So for example, if the patient tells you that he has drenching night sweats, you could think about lymphoma. And then bone pain sometimes also points to a leukemia, a myeloma, or a metastatic cancer which has spread to the bone. The past medical history can also give you some clues. For example, if the patient has peptic ulcer, which can cause bleeding into the gastrointestinal tract and subsequently lead to the anemia, they will describe epigastric pain. The drug history might tell you that our patient has been taking things like aspirin, a non-steroidal anti-inflammatory draw your attention to the cause of the anemia. Sometimes if the patient has been on steroids too, that can also cause ulceration in the GI, peptic ulceration. And so these things, you have to elicit them from your drug history. Now, on systemic inquiry, you'd realize that the patient might give you other symptoms that might tell you what is causing the anemia. So, for example, the patient tells about chronic diarrhea, weight loss, change in bowel habits, or rectal bleeding, then you would start thinking of the GI as a cause of the loss. Okay, so for example, if there's chronic diarrhea, then you wonder, is there some malabsorption going on? Or there is rectal bleeding, then you'd wonder about hemorrhoids. Okay, so further in the systemic inquiry, for a woman of childbearing age, you need to go into detail about their menstrual blood loss. So how long does the menses last for? How many pads does she change? Has there been a change in the volume of blood loss? As again, so that is indicated by how many pads they use. Has there been a recent change? Do they feel dizzy during their menses? Is there any change in the pattern or in the length of the bleeding? All these are very important. Now, it's important to find out if there is hematuria. And usually when there is hematuria, which is heavy enough, it is usually the presenting complaint. Okay, so social history. We know that alcohol consumption is associated with gastritis, which will lead to bleeding from the stomach or bleeding ulcer. It can also lead to a microcytic anemia. can cause liver disease, which would lead to variceal bleeding. So all these things can cause anemia. So whenever you have a patient with anemia, it's also important to find out about alcohol intake. In medical history, it's also important to find out about their diet. So is there any nutritional deficiency? What are they eating? Is what they are eating sufficient to give them the raw materials for production of red blood cells? So these are folic acid, iron, vitamin B12. Are they getting enough of these in the foods that they are eating? And we know that alcoholics don't eat well. So once a patient is an alcoholic, the diet will also be deficient. Then it's also important to inquire about vegetarians, because vegetarians are prone to vitamin B12 deficiency, because vitamin B12 is from animal sources. So if the patient is a vegetarian and is not on supplements, then this patient might likely have anemia. Okay. So when you take the family history, you want to find out if there's a family history of blood disorder. And this is usually very significant in children. So sickle cell disease, for example, you want to find a phenotype. If they are, then it's possible that the child might have sickle cell, for example. Then the ethnicity. We know that sickle cell is common in Afro-Caribbeans and people of Mediterranean origin. And beta thalassemia is also common in people of Mediterranean origin. So you might want to find out about these as well. So we move on to examination. So when you examine the patient and there's anemia, it's important to pay attention to pallor. So that pallor is from the mucosal membranes, the palms of the hands, the soles of the feet. But pallor sometimes can be an unreliable guide. So you definitely have to request for the hemoglobin levels of the patient. Then there are certain specific types of anemia which give you characteristic symptoms. A B12 deficiency. You want water? If the anemia is due to B12 deficiency, the patient will present with peripheral neuropathy, and this will present as an absent ankle jack. So you have to take a look at these. Now there are some features too that you see on the patient. So, for example, patients with thalassemia, we see that their head is square shaped, especially the children, because there's massive expansion of the bone marrow for production of red blood cells. And so they have a typical shape of head. There's sometimes gingival hypertrophy. So there's overgrowth of the gums when you are looking specifically at certain type of leukemia. Then the same leukemia can also cause photophobia and stiffness. So when you examine the patient, you would realize that the neck is stiff. If the anemia is associated with jaundice, for example, hemolysis occurring in G6PD or sickle cell disease, you realize that the patient will have a yellow coloration with sclera. And sometimes too, if it is a chronic hemolytic anemia like sickle cell, you'll have skin ulcerations. When you examine the liver, the spleen, you'll find that those will be enlarged, and then the lymph nodes would also be palpable. Now, if there is any pathology in the gastrointestinal tract, these will be indicated by tenderness in the epigastric region. That is, if you are looking at peptic ulcer disease or abdominal mass. So the liver will be enlarged, the spleen will be enlarged. Or if you do a rectal examination, you realize that the patient has hemorrhoids, or there might be some lesions in the rectal mucosa, which might indicate maybe a tumor or something which is causing the bleeding. So we know that when we are examining the lymph nodes, we need to know how many lymph nodes there are, what is the size, what is their consistency. So consistency means that is it hard, is it firm, is it discrete, or are they confluent or stuck together? Is it mobile or is it fixed to where the lymph nodes are? So to explain further, if you palpate the lymph nodes and you realize that they are firm or hard, that usually indicates cancer or a malignancy. If you realize that the lymph nodes are fixed either to the skin or to the underlying structures, that is also indicative of a malignancy or cancer. Then if the skin around them is abnormal, maybe it's ulcerated, that also has a bad indication. So if we all know where the lymph nodes are in the body, so we pay attention and we examine them accordingly. Yeah, so this is just to explain what I was saying, that if there's an infection, usually the lymph nodes are tender. And then when it's a tumor or a malignancy, neoplasm, the neoplastic lymph nodes are usually not painful. Then HIV, tuberculosis, they usually cause generalized lymphadenopathy, meaning that you have lymph nodes everywhere, the neck, the supraclavicular region, the armpits, everywhere, inguinal region. You examine the patient from head to toe, and all their lymph nodes are inflamed. Usually, you have to think about things like TB and HIV infection. Okay. So these are various lymph nodes and enlargement and where you will find the problem. So for example, if you have lymph nodes in the axilla or in the armpit, it can either indicate an infection of the upper limb or a breast infection. So breast abscess, mastitis, and so on. If you come to the lower limb, the inguinal region, if there's an infection, if you have a genital ulcer, if you have genital herpes, the lymph nodes will be inflamed and so on. Usually, when the lymph nodes are asymmetric, it usually suggests a lymphoma, which is a cancer of the lymph nodes. And the only way you can confirm a lymphoma or cancer is when you take a sample of the lymph node and you send it for biopsy. And this is called an excision biopsy. Yeah. Boy there. Oh. So and usually a lymphoma is indicated by the rubbery nature of the lymph node. When you examine the lymph node and you palpate it, you realize that it feels rubbery, and usually this tells you that we are dealing with a lymphoma. So we move on to the liver and the spleen. So when you palpate the abdomen and the liver and the spleen are enlarged, it is called a hepatosplenomegaly. And there are certain things that cause a massive hepatosplenomegaly. So myeloproliferative disorders, that is tumors of the bone marrow, or lymphoproliferative disorders, that is tumors of the lymph nodes or lymphatic vessels, and then congestive cardiac failure. These three things would cause hepatosplenomegaly. But we have isolated causes of splenomegaly, massive and then mild or moderate. We say that the spleen is massively enlarged, that is massive splenomegaly, when you have a spleen size of more than 10 centimeters from the costal margin. And malaria is one of the causes. Leishmaniasis is one. Tumors. So every time you see that the spleen is enlarged, think of tumors, lymphomas, leukemias, and then also think of infections like malaria, tuberculosis, Epstein-Barr virus, and then leishmaniasis. So let's look at the hematological. These are broadly into two major types. So we have acute leukemia. Akosia, bring the cup. Eba, Tabie, don't go to the bed. Tashi, no. Eh? So for the cancers, there are two major types. We have acute and chronic hematological cancers. The naming has to do with the timing. So the acute forms are abrupt in onset, and then the chronic ones take a longer course. And usually these cancers are very aggressive in nature. Most of the time too, the chronic forms cannot be cured, but you can control them with treatment. So for leukemia, for example, we can have acute leukemia and chronic leukemia. And for the chronic leukemias, they usually affect older individuals. And because of the slow growth or the prolonged nature of them, usually the patients may not show much changes. But over time, you realize that the patient loses weight, the patient sweats, and then you can have other constitutional fever symptoms like recurrent fever and so on. So that is for the red blood cells. Now let's look at the bleeding disorders. So usually disorders of primary hemostasis, that is the mechanisms that help with blood clotting or stopping of bleeding, they usually affect the mucosal surfaces. And an example is the platelets. And then disorders of secondary hemostasis. I don't know if you've done primary and secondary hemostasis in physiology. That would help understand. Okay, so let me explain what primary and secondary hemostasis is. So when you have a cut, something cuts your hand or your leg or whatever, you have a primary process which deals with the blood clotting. And that usually involves platelets at the scene of the cut. And that is called primary hemostasis. Then, after a while, the secondary hemostasis kicks in. That is where the clotting factors would form the clots and then stabilize the clot. So that's secondary hemostasis. So when you have disorders of primary hemostasis, usually those ones affect the mucosal surfaces. So if a patient complains of gum bleeding, for example, or bleeding, easy bruising, that one usually has to do with the disorders of primary hemostasis. So maybe they might have problems with their platelets. But if they are having, that is, problems with the clotting factors, you realize that the bleeding is deeper. So they bleed into their muscle and into their joints. Okay, so that is one way to distinguish between the two. And an important aspect of the history will be the duration of the bleeding. If the bleeding is something that has been from birth, then you start thinking about inherited disorders. For example, hemophilia. So one very important question to ask if the patient is a male is to ask whether there's a history of bleeding during circumcision, because that's usually one of the first indicators, or bleeding from the umbilical cord. So these two things are important. A patient may not necessarily remember, but in pediatrics, those are very important questions that we need to ask about. Another indication of a hemostatic defect is frequent bleeding from minimal trauma. So maybe patients hit the leg against something very trivial, but then bleeds excessively. Okay. Or they are having a procedure which normally wouldn't lead to so much bleeding, but the patient bleeds excessively. So like dental extraction, for example, or excessive menstrual bleeding could also be an indication of a bleeding disorder. Okay, so it's very important for you to ask these things in your history. Then when it comes to drug history, you also need to find out about medications that the patient is taking. For example, aspirin. Aspirin is an over-the-counter medication that we buy from the pharmacy, but it can lead to bleeding disorders. So it's very important for you to ask about certain medications that the patient is on. Okay. Then is when it comes to the examination, looking at the nature of the bleeding or the size of the bleeding can also give you an idea of what's going on. So if there is bruising or purpura, usually that tells you that there's an abnormal platelet function. So bruising is superficial. So you see the bruise on the skin, and then the purpura is tiny spots or rashes from pinpoint bleeding. Usually in a kind of skin, you don't see it as reddish. You would see some blackish spots. And when you press it, it doesn't blanch or it doesn't change color. And so that is an indication that you have superficial bleeding or platelet abnormality going on. Sometimes when you examine the retina of the patient, you would find that there are retinal hemorrhages, and this is done by the eye specialist. So when you find all these things, then you have to do look at your differential diagnosis. So meaning, what can it be? It can be thrombocytopenia, that is decreased amount of platelets in the blood. It can also be a liver pathology. So you need to, because the liver produces the clotting factors, okay? So that's where the liver comes in. So if the clotting factors are not produced, then there will be excessive bleeding. So liver pathology can also be an indication. So you need to examine the patient carefully and look for other things. If you have a liver pathology, for example, you have leukonychia, that is decreased whitish coloration of the nails. Or you can have spider navy, or you can have striae, and so on. So all those things can indicate a liver problem. Now, how do you investigate a patient with a bleeding disorder? So you realize that this patient has abnormal bleeding. What do you do? So you ask for a full blood count, and it will indicate a thrombocytopenia, that is decreased levels of platelets on the full blood count. Then you also ask for a blood film. The blood film will confirm the thrombocytopenia. So when they look at the blood film under the microscope, you realize that yes, the platelets are small. Maybe their size is also small, or they have abnormal structure. They can also indicate other abnormalities, for example, increased white blood cells or abnormal white blood cells, in which case you start thinking of leukemia. Then you ask for your clotting tests. So prothrombin, INR, they will test the extrinsic pathway. And then activated partial thromboplastic time will check the intrinsic pathway. So these two will help you to determine where the problem is coming from. I don't know if you have done this in physiology, but maybe just quickly revise it so that you understand this better. INR, or the prothrombin time, is abnormal, then these are some of the differential diagnoses. So warfarin, liver problems, vitamin K malabsorption, hemorrhagic disease of the newborn, disseminated intravascular coagulation. Then if you do your APTT test and it is abnormal, then straight away you should start thinking about things like hemophilia or von Willebrand's disease. Or maybe the patient is on warfarin or heparin. Also, if the patient has a liver disease, because the clotting factors are in the liver. So if the thrombin time is abnormal, then you are looking at fibrinogen specifically, or problems with heparin. Okay. So let me just give a brief format for the examination. So the patient is on the examination bed. you look generally at the skin of the patient. You are looking for any bruises on the skin or any particular or pinpoint hemorrhages on the skin. Then you also examine the conjunctiva, the palms, the soles of the feet, the mucous membranes for pallor. You also look at the eyes for jaundice. And then you do a generalized examination for lymph nodes, the whole body. Then it's also important for you to check for swelling under the skin, because sometimes lymphomas and leukemias can give you swelling. Then you palpate the bones to check if there is bone pain. And then you examine the abdomen for the liver and the spleen. So if a patient comes to you complaining of anything that gives you an impression that you might have a problem with the hematological system, these are the steps you need to take for the examination. In fact, the examination of the hematological system is one of the easiest because it doesn't involve auscultation, it's just palpation. And then for the palpation, you are going to specific organs. All right. So I'll pause here. If you have any questions, you can ask.
Madam, I have a question.
All right.
Okay. And the next one, I have a, and then for some time now, for
Can
2
you
years
start the
now,
question
I've been
again?
having
I
this
didn't
trouble.
hear you very well.
Okay.
Can you please
There's a
start the
small
question
girl.
again? I didn't hear you well.
Okay. There's a small
Yes.
girl, okay, who is
Mm-hmm.
having issues. Now, when you check, you see that part of the bones, like the flesh on the bone is swollen up, the leg, and then she'll be having pains, complaining here and there. It can go off and it will come back again. So after a severe checkup, we realized that the blood anemic. She was anemic. Her blood this thing was 6 point something. So my question is, could this be let me say a liver issue, or it could be issue with the blood itself?
You said she was having bone pain.
Yes, you see that when you hold the wrist, you see it's swollen.
Did you check for sickle cell?
Yes, she's not sickle cell.
Okay.
Yes. So I was thinking if it's leukemia or maybe it's liver something, because per the doctor who checked on her, they asked us to go and do a photo, blood filming comment and then one stuff. But then after the shot, we realized that there was no inflammation of the liver or anything like that.
But so what did the film comment show? Because it can also be leukemia.
We've not gone for the film comment analysis yet.
It could be leukemia. Because if you examine the liver and the liver is normal, it may not be a liver problem. But with the bone pain, it might be leukemia.
Okay. Because it started, she's 13 years. It started 2 years ago. When it comes, she can slim down to, you think she's sickle cell. But then when it's off, she can be normal throughout the whole about 6 months, then it comes again. Yeah.
But I would, has she gotten blood? Has she been transfused before? So what did they do about the HB of 6 that was found?
Currently she's on, we are waiting for the film analysis so that we can take it from there. But currently she's on folic acid. And then yes, folic acid and some iron supplement.